Chapter 11, Healthcare Quality and Safety Across the Care Continuum. So the main objective is to deliver better quality and safer care. So quality of care actually affects a population's overall health. So the Institute of Medicine put out To Err is Human back in 1999. The main focus of this was a national spotlight on the health system's shortcomings. So here they're saying systems rather than people are the issue. What is not measured cannot be improved. Coordination is important to quality care and safety. 4 factors that affect health are clinical care, health behaviors, social and economic factors, and physical environment. And so they're going to define quality as the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. Also, this also comes to understand the quality of health care delivered in a system that can keep patients safe is essential to advance population health. So quality measurement is not a new concept. It's been around since the early 1660s. Quality measures are developed by stakeholders based on 4 different criteria. Is there sufficient evidence to indicate the measure can affect quality? Is the measure scientifically acceptable to produce valid and reliable results? Is the measure usable in quality improvement and decision making? And then is it feasible to collect data on the measure? The healthcare industry can be described as a set of inputs and outputs. So the inputs would be like health behaviors, social and economic factors, the physical environment, and then outputs would be outcomes such as quality of care. Differences among communities, which would be your inputs, explain the large variation in practice patterns and patient outcomes in the United States. So here are some challenges to measuring quality and safety from a population health perspective. Healthcare is delivered in a fragmented system which incentivizes volume and not value of services. So in other words, quantity over quality. With little interoperability among multiple existing health information systems, it is difficult to assess the health status of an individual patient or population. So it's difficult to follow patients from other specialties due to electronic health records not being compatible with each other to share this information. And then also care for people with chronic conditions is not well coordinated. Coordination of care is lacking when a patient has a chronic condition. Doctors don't know what the other one is doing. So beginning in 2000, the Centers for Medicare and Medicaid Services implemented a quality initiatives incrementally with increase in sophistication to ensure quality health care for all Americans through accountability and public disclosure. CMS standardized quality data collection and reporting processes, initially focusing on the hospital setting. Current initiatives focus on publicly reported quality measures for nursing homes, home health agencies, hospitals, dialysis facilities, and ambulatory care providers. And then also CMS launched Medicare.gov quality comparison website where performance by hospitals, physicians, and alternate care facilities is posted. So the National Committee for Quality Assurance developed the Healthcare Effectiveness Data and Information Set, which is called HEDIS, which is the most widely reported set of measures of evaluations of health plan and provider performance. So HEDIS was developed to enable consumers to compare a health plan's performance with another health plan and with national and regional benchmarks. Many health plans tie physician incentives and reimbursement on performances on the HEDIS metrics. So HEDIS measures address a broad range of quality and safety concerns, such as appropriate management of chronic conditions and access to prenatal services. And so also too, it is from recommended screenings to appropriate medical management of chronic conditions to assess the importance of services. So then the National Committee of Quality Assurance and other measure developers submit quality measures to the National Quality Forum for the endorsement. So the National Quality Forum has established a process for validating and endorsing sound and reliable metrics. A nonprofit organization, and it's dedicated to improving the quality of healthcare in the U.S. So the National Quality Forum embodies a 3-part mission. It's to set goals for performance and improvement, to endorse standards for measuring and reporting on performance, and also to promote educational and outreach programs. So the Institute for Healthcare Improvement actually gained recognition for its campaigns aimed at reducing morbidity and mortality. And this was brought together through leaders to devise strategies for improving healthcare quality and safety. And the Institute for Healthcare Improvement developed and launched the Triple Aim, which is designed to enhance patients' experience of care, improving the health of populations, and also reducing cost. Triple Aim became the building block for the National Quality Strategy. So the National Quality Strategy was established as part of the Affordable Care Act and serves as a catalyst and compass for the nationwide focus on quality improvement efforts and approach to measuring quality. So the National Quality Strategy its strategy is to concurrently pursue the three aims: the better care, the better health, and the lower cost. So the role of health information technology, the American Recovery and Reinvestment Act of 2009 established financial incentives for hospitals and other providers to invest in and utilize health information technology, or electronic health records, under the Meaningful Use program. Now, this program stipulates that providers demonstrate performance on certain CMS-defined core and menu measures on their electronic health records. The goal of the Meaningful Use program is to build a national health information technology infrastructure that might be leveraged to improve population health, patient engagement, and access to care. So health information technology has the potential for enhancing clinical care processes and improving health outcomes by providing clinicians access to current treatment guidelines and decision support tools, by alerting clinicians to patient allergies and potential drug-to-drug interactions via electronic prescription systems, helping clinicians identify and manage select patient populations, such as patients with diabetes, and also helping clinicians track their performance on quality measures based on comparisons to national benchmarks. So Patient Protection and the Affordable Care Act actually developed a few more programs. They developed the Value-Based Purchasing Program, CMS Hospital Readmission Reduction Program, Patient-Centered Medical Home, as well as accountable care organizations. Now, the accountable care organizations and the patient-centered medical homes are intended to improve healthcare quality and safety across care settings. So value-based purchasing, this program bases payment on facilities' performance on a variety of cost and quality measures. So programs may vary in design, but share common goals of decreasing cost and improving qualities. Program components include defined performance goals for select quality metrics, as well as financial incentives for hospitals and individual providers. Its reported results of pay for performance initiatives are mixed. Questions still remain on their ability to create sustainable value and affect health outcomes. Federal and commercial programs continue to multiply. So the value-based purchasing aligns a portion of Medicare payments with provider performance on quality metrics, and also it will affect providers in multiple healthcare settings. So the CMS Hospital Readmission Reduction Program, this is where hospitals are subject to rate reductions for high rates of readmissions due to conditions deemed preventable, such as a heart attack, heart failure, or pneumonia. Insufficient attention to patient handoffs to the primary care provider pose a high risk for error and inadequate provider communication follow-up. So when a patient is discharged from the hospital, the primary care provider needs to be made aware of that, and also the reason why the patient was in the hospital, so that the primary care provider can continue the care as the patient is at home. Patient-centered medical homes. These are enhanced multidisciplinary team care with a primary care physician coordinating care among different specialty providers and practice sites. They're improved access to care, so they have extended hours, improved patient-provider communication and payment structures, and also focus on preventing illness and engaging patients in their own health. These patients have the opportunity to become actively engaged in their own care, which also enhances the experience and satisfaction of the care given for those clinically complex patients. So Accountable Care Organization, or ACOs. It's an affiliation of healthcare providers like hospitals, physicians, and others that collectively agree to be accountable for the health and associated costs of a defined population. ACOs are held accountable for multiple quality metrics, such as preventative screenings, blood pressure control, and things of that nature. The Medicare Shared Savings Program is an ACO model that enables providers to share in the cost savings realized from providing more appropriate, better quality of care. The Patient Safety and Quality Improvement Act of 2005 led to the creation of the Patient Safety Organization and a new framework for collecting, aggregating, analyzing, and more effectively addressing medical errors and adverse events. So patient safety organizations are not focused on applying sanctions to prevent their reoccurrence. A patient safety organization is defined as a group, institution, or association that improves medical care by reducing medical errors. An organization can seek patient safety organization status if it is primarily active, or if its primary activity is to improve patient safety and the quality of healthcare delivery. It must also meet 15 statutory requirements as well. Information reported to the patient safety organization is protected from legal liability and professional sanctions. So this distinction serves to calm fears and encourage reporting and review to promote improvement. So for inpatient hospital quality improvement, groundwork was laid by CMS's Premier Hospital Quality Incentive Demonstration Project of 2003, under which participating hospitals earned incentive payments for achieving performance goals on VBP metrics. So the VBP metrics are useful to providers in managing care for populations of patients. Financial penalties were implemented under the Deficit Reduction Act of 2005, where it says hospitals no longer received additional payments for care rendered to patients with healthcare-associated conditions. So hospital-acquired conditions like bloodstream infections, UTIs, falls, pressure ulcers from resulting medical errors are a leading cause of mortality and financial burden on the healthcare system. These cases can be reduced or eliminated through the consistent use of evidence-based guidelines. So this is pretty much why there's a penalty for it. The shift from incentives to penalties reflect a drive toward improving the standard of care. So under a comprehensive CMS value-based purchasing initiative back in 2012, payments to hospitals are based on performance in 6 domains: safety, patient and caregiver-based experience and outcomes, care coordination, clinical care, population community health, as well as efficiency and cost reduction. So for ambulatory care quality improvement, eligible providers can report on almost 300 unique quality measures ranging from lab values to smoking cessation counseling. CMS's Physician Quality Reporting System is a voluntary pay-for-reporting program for Medicare providers. So the PQRS is the first CMS program to tie performance on quality metrics to incentives and penalties. Providers who do not participate in quality improvement programs are faced with financial penalties. So for quality and patient safety and alternate care settings, we're going to look at retail clinics. Now, retail clinics are walk-in medical facilities located inside pharmacies and retail chain stores. Care is delivered by usually a nurse practitioner, often without a physician on the premises. A growing segment of the U.S. population, estimated 4.1 million in 2010, visits pharmacy-based nurse practitioner staffed clinics for preventative and non-emergent care. The Convenient Care Association publishes quality standards and conducts quality certification reviews of member clinics. And actually, I just saw one of these come up in our local Kroger marketplace. So they do pop up in a lot of different locations, and they are definitely becoming more popular. Now, urgent care centers is another facility that's been popping up quite a bit lately. There are more than 9,000 facilities that had operated in 2014. The American Academy of Urgent Care Medicine offers an accreditation program and a process by which organizations can measure their performance against national benchmarks. So the long-term care now as a concept has evolved to encompass multiple settings and forms based on the patient's needs and wishes. More than 15,000 Medicare and Medicaid certified nursing homes are in the United States. Current nursing home quality measures are endorsed by the NQF and publicly reported on the CMS Nursing Home Compare website. Under the Affordable Care Act, long-term care hospitals must submit data to CMS on an increasing number of quality measures like catheter association, urinary tract infections, and pressure ulcers, just to name a few. So for home health agencies, CMS requires more than 10,800 Medicare certified home health agencies to collect and report performance data on the Outcome and Assessment Information Set, or OASIS tool. A subset of these quality-based metrics is posted on Medicare.gov Home Health Compare website. So the CMS Health Compare website provide information on the performance of a broad range of healthcare providers, including hospitals, physicians, nursing homes, and home health agencies. Currently reported quality measures are related to managing pain and treatment symptoms, treating wounds and preventing pressure ulcers, preventing harm, and also preventing unplanned hospitalization. So, from the consumer's perspective, a goal of the CMS Quality and Safety Strategy for 2013 and beyond is to promote person and family engagement as partners in their care. The Affordable Care Act calls for a focus on the patient experience, self-management, and shared decision-making. CMS intends to alter the healthcare landscape by encouraging and incentivizing providers to actively engage patients in their care. The consensus is that informed, engaged consumers will select high-quality providers and share in the decision-making process. Consumer assessments of healthcare providers and systems, or CAHPS, surveys enable objective data collection and public reporting related to perceptions of healthcare. So this concludes Chapter 11. If you have any questions, please let me know. Thank you.